Good morning, everyone. Uh, my screen is visible.
Yes, yes.
My patient is 23-year-old male, resident of UP, with no comorbidities, no habits, and no family history of cancer. Evaluated for complaints of fever, high grade on and off since past 3 months, weight loss of 6 kg over 3 months, left supraclavicular region swelling, progressively increasing in size since past 3 months, swelling over the anterior left chest wall since 2 months, and progressive shortness of breath since 2 months. Patient had no history of hemoptysis, productive cough, exertional weakness or drooping of eyelids, swelling over front of the neck, difficulty in swallowing, gynecomastia, testicular swelling, back pain, nodal swelling anywhere else in the body, or melena. Patient had no hoarseness of voice, swelling or redness over face and chest wall. So, based on history, to summarize, 23-year-old male with no comorbidities, no habits, presented with left supraclavicular nodal swelling and left anterior chest wall swelling, with exertional breathlessness with B symptoms of 3 months duration. So, differential diagnosis based on history would be lymphoma, tuberculosis, germ cell tumors. Should I go ahead?
Devanshee,
Yes, sir.
am I audible?
Yes, sir.
So, Devanshee, when you present the history in a long case, no, there's you have to elaborate the history of presenting illness. I think one of the class in the previous class also I mentioned that. So, whenever you present a long case, no, you have to start from the day the patient was asymptomatic, and in a chronological order, one by one symptom, um, elaborate has to be done, and what treatment he received for the same in between. So this is like presenting a short case, you know. So when you say that the patient has presented with supraclavicular swelling, so how big was the swelling? After that, what he did? After that, he developed a chest wall swelling. How severe was the breathlessness when he started? And after that, what investigation has been done, and currently, what is the situation? So this is how it has to be presented in a chronological manner. You know, you understood?
Yes, sir.
Do you want to elaborate, as Lingaraj said? Do you want to elaborate on this, or you don't have that information?
Yes, ma'am. So, 23-year-old male resident of UP presented with complaint of fever, which was high grade. Around daily spikes were there, and with in between a period of no fever. In between period of 4-5 days of no fever, followed by high grade spikes of fever. Daily one spike, and Tmax was 101, 102. This was present since past 3 months. Patient had unintentional weight loss history. Weight loss was patient was initially around weight of 66, 67 kg, and now he had lost 6 kg, which is six. Now he is 60 kg of weight. And this was unintentional in nature. Patient had left supraclavicular fossa swelling, progressively increasing in size since past 3 months. So initially the swelling, initially he didn't, when he noticed the swelling was approximately size of 1 into 1 centimeter in size, approximately size of uh, peanut, maybe approximately size of peanut, and then it gradually increased over a period of 3 months. No sudden increase in last 1 or 2 weeks. Patient also had complaint of swelling over the left chest wall, which appeared after the supraclavicular node. After he noticed supraclavicular node, the swelling was in swelling was infraclavicular in infraclavicular region, and it was initially it was gradually increasing in size, and it was uh, not movable according to patient. And he had progressively increasing shortness of breath since 2 months. So this shortness of breath was exertional only in nature. Initially, he was able to climb 3 flights of stairs without any fatigue or shortness of breath. But now he was only able to climb only one flight of stairs, and no shortness of breath at rest. So to summarize, 23-year-old male with no comorbidities, no habits, with left supraclavicular nodal swelling and left anterior chest wall swelling with exertional breathlessness and B symptoms of total 3 months duration. So to favor uh, lymphoma, patient has left supraclavicular nodal swelling with B symptoms and exertional breathless, which could be due to pleural effusion or mediastinal mass, or maybe probably or due to low hemoglobin, which could be due to bone marrow involvement in lymphoma. For patient to have tuberculosis, the age group fits in lymphoma and germ cell tumor group, and tuberculosis, as it is endemic in our country, with patient having fever, night sweat, fever, weight loss, and supraclavicular nodal swelling, it could be one of the possible DDs.
How do you explain the anterior chest wall swelling, Devanshee?
Ma'am, for tuberculosis, it can be due to cavity which is communicating with pleura, and there is empyema collection formation over the anterior chest wall.
Empyema will have collection on the chest wall?
Not on chest wall, but if that collection is if pleural empyema will have collection in the pleural cavity, and if it is communicating with if it has ruptured and it is forming sinus tract over the connecting with the chest wall.
And do you think history is consistent with that kind of a presentation? Because this seems like somebody who has no access to any healthcare goes on with an untreated TB for such a long time that that person not only has developed empyema but has got a communication with the anterior chest wall. How many TB you have seen like that?
No, less likely.
Just for the sake of, I've told multiple times, I know that we have high incidence of TB, but that doesn't mean that we bring in TB anywhere and everywhere. I can understand you want to keep it at last, but having a second differential diagnosis before germ cell tumor, at least to me, it doesn't seem likely.
Okay.
So one, how do you describe each one of the symptoms anatomically? So you said patient is having pleural effusion. So what in the history would you take which will suggest that it's the mediastinal mass versus the other things which are responsible, what you attributed to responsible for the dyspnea on exertion?
For patient having mediastinal mass and pleural effusion, he will have some amount of coughing, and if he has pleural effusion, then there will be increase in chest pain with taking deep breath, and while coughing there is increase in chest pain. While in mediastinal mass, there will be only coughing only, no increase in chest pain over deep inspiration. And if the exertional breathlessness is due to anemia, low HB, then there will be no coughing or chest pain while taking deep breath.
So one, the chest pain and pleural effusion usually comes at when it's in the early phase, when you have some pleuritis there. As the, if it's been there for 3 months, it's very unlikely that you will have chest pain with, or a pleuritic type of chest pain. It's very unlikely.
Yes.
When you're talking about breathlessness because of mediastinal mass, you would expect that person to have some amount of SVCO.
Yes.
So have you asked whether there is facial, fullness which has come over a period of time?
Yes.
The second thing is whether, there is any postural variation in terms of breathlessness. So what would you expect in somebody who has mediastinal mass where there is, exertional breathlessness? Would you ask whether there is any increase in breathlessness while they are lying supine?
Yes, ma'am.
Whether it becomes better with changing posture to right lateral or left lateral, whether there is any difference or not. Yeah. So
yes,
all those
yes.
things will help you whether there is one, mediastinal mass, second, whether there is pleural effusion, which is unilateral or bilateral. Having chest pain is something which is unusual. Most of the time, the cuff which will come with the pleural effusion, or for that matter, mediastinal mass, unless there is consolidation, is going to be more of a, what kind of a cuff, which will be non-productive cuff.
Yes.
So mediastinal mass, if they have obstruction and there is secondary consolidation, they may have productive cuff.
Yes.
And in a patient who has anterior chest wall swelling and on the same side there is supraclavicular nodal swelling, the more likelihood that it's the nodal mass, which is there not only in supraclavicular area, but even infraclavicular and probably in the mediastinum, which is why you are seeing this kind of a contiguous presentation where there is supraclavicular node swelling as well as anterior chest wall swelling.
Okay.
Okay. So in a 23-year-old male, since he has B symptoms, the first preference would be lymphoma. And you can keep germ cell tumor as your second differential. TB with this kind of a bulky nodes, etc., is a lower on the cards rather than on top. What additional thing would be there? Which lymphoma are you talking about here?
Ma'am, differentials for lymphoma will be Hodgkin's or PMBCL versus lymphoblastic lymphoma.
Correct. So amongst three of them, which one would you think has top, seeing the temporal course and how rapid or how slow the symptoms are? How would you rate all three lymphomas here?
So, based on the course, PMBCL is more possible. PMBCL is more likely in this patient. In Hodgkin's lymphoma, course will be more slower over a period of over a long duration of time, and in lymphoblastic lymphoma, the course will be more faster. It will be a most likely acute presentation within a month or less than month history of symptoms.
Not necessarily that it will be less than month, but the amount of these symptoms are relatively lesser in lymphoblastic lymphoma. But yeah, I mean, these are all matter of comparing one against other. So agree that PMBCL followed by Hodgkin's is a likelihood, and since there are too many B symptoms and the way the disease has come in, it looks more like these two rather than lymphoblastic lymphoma.
Yes, ma'am.
Why did you ask the history of drooping of eyelids?
Paraneoplastic syndrome of thymic carcinoma or thymic hyperplasia.
So do you think that this can be still a thymoma or thymic carcinoma or thymoma with myasthenia, what you're talking about?
No, ma'am.
Why not?
Ma'am, patient has anterior chest wall swelling with B symptoms, and B symptoms are fever and weight loss. So fever. B symptoms are not explained in thymic carcinoma and or thymic hyperplasia, and no other diurnal variation in weakness or no uh, exertional weakness is there.
Okay. Over from my side, Lingaraj and Akhil, anything?
Nothing, ma'am. You can go ahead.
Yes. So going to the examination, patient is fairly built and fairly nourished, conscious, cooperative, and well-oriented to time-place person. Weight is 60 kg. ECOG PS is 1. No pallor, icterus, clubbing, cyanosis, or limb edema was there. Temp temperature and pulse BP, respiratory rate, SpO2 were within normal limits. There was on general examination, visible bulge was seen over left anterior chest wall, 3 into 2 centimeter in size. So going to systemic examination, testicular examination was normal. Uh, examination of cardiovascular system, central nervous system, and respiratory system was within normal limits. There was no hepat or splenomegaly on abdominal examination, and 3 into 2 centimeter swelling, which was firm in consistency, peaks to adjacent bone, manubrium sterni, with free overlying skin was palpated opposite left first intercostal space and second rib. On peripheral lymph node examination, this supraclavicular lymph node, 2 into 2 centimeter size, single discrete swelling, firm and mobile in nature was noted. Rest of the nodal examination was within normal limits. So to summarize, a 23-year-old male with no comorbidities, no habits, with history of left supraclavicular nodal swelling, exertional, breathless, left-sided chest pain with B symptoms of 3 months duration, with 2 into 2 centimeter size left supraclavicular firm mobile discrete lymph node, and 3 into 2 centimeter firm fixed chest wall lesion opposite left first intercostal space and second rib. So differentials after examination will be lymphoma, which are in highest likelihood PMBCL, gray zone lymphoma, followed by Hodgkin's lymphoma and LBL. Second DD will be germ cell tumors, less likely, and tuberculosis less likely.
So Devanshee, is this patient is in supravenica obstruction?
No, sir. He did not had any venous prominent veins over the chest wall or redness or swelling of the face and chest wall.
Okay, so if there is no prominence of veins and no redness, then there is no SVCO.
Also, sir, no limb edema was there, and no breathlessness at rest was there.
So what is the early feature? How SVCO patients who have very subtle SVCO present? There is a grading
Headache.
for SVCO. Are you aware of that? There is a SVCO grading, 0 to 5.
No, sir.
Okay. So read about it. So in early SVCO, like in grade 1, grade 0 is when you have only radiological features of vena cava obstruction. But when you have grade 1, there is facial puffiness, no, and puffiness around the eyeball, and periorbital puffiness, and that is more so when the patients lie down for long, typically in the early morning. Okay, so these are very subtle, and when you examine the patient, they may not tell you in the history, but when you examine, you have to ask those symptoms, because they will be present for some time and they will wane off as the day passes, so that is a early SVCO. And then there is grade 2, grade 3, depending on that, the severity of the symptom. worsens. So you should read about that. And whenever you summarize a case of mediastinal mass, you should always write at the end that whether the patient is in SVCO or not. Okay.
Yes, sir. Yes, sir.
Okay. So after this, you have a DD of lymphoma and then followed by germ cell tumor. Okay. So how do you approach this patient further?
So I will do first of all routine blood investigations, CBC, MBC, biochemistry, electrolytes, LDH, AFP, beta HCG, and viral markers. And based on initial blood tests, we will be able to rule out germ cell tumors. And if we have ruled out, then we will go ahead with PET scan and excisional biopsy of supraclavicular lymph node.
So when you say investigations, never say biochemistry. Biochemistry is a very broad terminology. So whenever you are presenting an exam, you should be particular what biochemistry you want. Okay?
Yes, sir. RFT and liver function test, renal function test.
Okay. So you want a PET non-contrast CT, is it? You want a PET CT or you want a PET CT?
Sir, as lymphoma is my first DD, I would like to get PET CT done.
No, you have written PET CT.
Yes.
What is the advantage of a contrast in a PET CT?
Sorry, sir. I don't.
Did you understand my question? Like
yes, sir.
So is PET CT okay for a patient for initial staging for any malignancy in the mediastinum? Is it okay? Any situation we will only do PET CT, not contrast. We don't need contrast.
So
PET CT is fine.
Patient-related contraindication. Otherwise,
apart from that, so what do you do? Which investigation you do for response assessment lymphomas?
PET CT, sir.
Yeah. So in response assessment, what we are interested is in Deauville score, right? So
yes,
at baseline, we need a contrast CT to exactly know the type of lesion, whether that is a node, that is a soft tissue. So to demarcate the lesion and its proximity to critical structure, we need contrast. Okay, so at baseline, we have to do a PET CECT. Okay.
Okay, sir.
Okay, so I don't think you should send a gene expert now.
Yes.
Yeah. So then you did an excisional biopsy. Okay. So what was the report?
So on routine investigation, there was some neutrophilic leukocytosis was there. RFT, LFT, and serum electrolytes were with TLS parameters were within normal limits. LDH was 168. Beta HCG and AFP were not elevated. PET CT was done, which showed there was mass in 8 into 5 into 5.5 into 5.4 centimeter mass with SUV of 14.7 in left lung with conglomerated anterior mediastinal mass, which was around size of 3.2 into 4.3 into 4.4 centimeter with SUV max of 14. And there was discrete lymphadenopathy in cervical level 4 and 5. Axillary and infraclavicular nodes and mediastinal nodes were seen. The largest lymph node size was 2.2 into 1.6 centimeter. There was also low-grade SUV2 uptake was seen in peripancreatic node, and FDJ with chest wall deposit was noted in left parasternal region in first intercostal space measuring 3.5 into 3.5 centimeter with lytic sclerotic changes in manubrium study. Uptake was noted, low-grade diffuse uptake was noted in marrow of axial and proximal appendicular keratin. And apart from that, no uptake was noted anywhere else. Core biopsy was done for this patient, which showed lymph atypical lymphoid proliferation, and on with large mononuclear and multinuclear cells, and on immunohistochemistry, the cells were positive for CD20, 30, and PEX5, and negative for ALK1 and EBV LMP. So CD3 highlights background of T cells, and OP2 and BOB1 highlights occasional large cells, and OP2 has not worked well in this this IHC examination. So impression was non-Hodgkin's lymphoma, B cell type unclassifiable, which features intermediate between DLBCL and Hodgkin's lymphoma. So likely gray zone lymphoma.
Okay, so yeah, go back. Okay, so this is intermediate between DLBL and Hodgkin. So what is the typical morphology and IHC of a Hodgkin's lymphoma?
So for Hodgkin's lymphoma, there are cancer cells are less than 10% in the overall specimen, less than 10. The proportion is 0.1 to 10%, and they are surrounded by inflammatory infiltrates. So cancer cells are large cells, and they are positive for CD15 and 30, and PEX5 may also be positive. CD20 is weakly positive, not and for
so positive where?
CD20 is positive in surrounding inflammatory infiltrates, and cancer cells are positive for 15 and 30.
Okay, so here, so what they have written? They have written large lymphoid cells are positive. No, they have not written about small surrounding cells.
Yes, sir.
So when you read a biopsy report, what you have in a Hodgkin, you have large RS-like cells, and surrounding that you have a background infiltrates. So whenever you read the immunohistochemistry, you have to read where this IHC is positive, whether it is positive in like the CD3 highlights the background T cells, right? So they have, so that is in the background, right? So what is the typical immunohistochemistry of Hodgkin? So CD30 is positive. So CD30 is always positive in Hodgkin. CD20 can be positive. PEX5 is typically weak, and an EVB LMP will be positive in classical Hodgkin. Okay, so I think Sridhar sir has joined. Sir, Sridhar sir.
Yeah, I'm here.
Yes, sir. Should I share the screen, sir?
Yeah, please.
Okay.
So
Devanshee,
can I just Lingaraj, can I just make few comments before we go to the slides?
Yes, sir.
So thank you, Devanshee and both Manju. Overview of clinical testing and all. My first point is, when you are describing the history and all, very nicely you said that idealistically you want to do the excision biopsy, but in reality there is no excision biopsy. There was a core biopsy done. Okay, and life is not so easy to interpret core biopsy, especially when you are dealing with the gray zones. So here, ideally, because there is a supraclavicular mass, there should have been an excision biopsy first point. Hopefully, you got my point. Lingaraj?
Yes,
Hello?
sir. Agree, sir.
Yeah,
Yes, sir.
did you get it? The second point I wanted to make was the terminology what you use. It should not be called as a non-Hodgkin lymphoma. It should be called as a B-cell lymphoma with features borderline between classic Hodgkin lymphoma and Hodgkin. So we don't know whether it is, though it is treated like non-Hodgkin lymphoma, but as per the pathology or the terminology, it's still called as a B-cell lymphoma with features intermediate between Hodgkin and non-Hodgkin. Okay. Lingaraj?
Yes, sir. So,
yeah, did you get these 2 points?
Yes, sir. Yes, sir.
Yeah. So now we can go to the slides.
Yeah. So once you stop share your screen, I will show.
Before we go into this loop, and maybe for all the residents, I just want to say that
there is some background noise.
Yeah.
There's some background noise. I'm not sure whether it's
So Actually, I'm using earphones. Very unlikely to have a background.
Okay, so I think the earphone wires are moving. That's probably the reason.
Yeah, I can't help it, man. So
No, no, this
I'm
is
actually.
fine. Better now.
So otherwise, what you do, I'll be reaching there in 10 minutes. If you want, I can come directly. And in the meanwhile, if you want to have some clinical discussion, you can have. Just here
This is
at.
fine. Sridhar, you can go ahead. It's better
Yeah.
audible now. Yeah.
Okay. For all the residents, I just wanted to say that when you are dealing with lymphoma or mediastinal mass, there are a couple of things in clinical history. Yes, we have done very nicely. You elaborated that it's not with thymic or disorder. But lymphoma in a mediastinal mass can be multiple sources. Like the most commonest source of the origin is thymic. Okay, you can get from blastic lymphoma, you can get PCL, and other sources are the joining hylar lymph nodes and other structures. So many times to differentiate between a thymic neoplasm like thymic thymoma or a thymic carcinoma and a Hodgkin lymphoma or a PMBCL, it will be difficult if you don't have any other structure. So we need to understand sometimes clinically, just when looking at the evaluation, not really differentiate between primary thymic neoplasm and thymic. Okay. Here we see that what you are seeing in the screen. Just want to highlight that we got multiple fragmented cores on the tissue, and there are the down column, the lower row of pictures actually highlights the difference in morphological areas. Somewhere it is showing the more dominance of larger cells, somewhere it's polymer. Can you go to the next slide, please? Hello.
Yes, sir.
Yeah. Next slide, please. Yeah, you can make out here the picture. See, I don't have a pointer right now. Are you able to make out there are some large cells which are having? Yeah. You can see this. There's an mixed population. Some are small dots, some are large cells. Okay. Next slide. Next slide. Yeah, here in this picture, what you're seeing is you are not seeing that kind of polymorphism. You're seeing sheets of large cells. You can see more of large cells and lesser of smaller cells. So at this point of time, at this point of what we are seeing, that there is a lesion which has got heterogeneity. Somewhere it is giving a polymorphism. If there is other areas which is not shaded. So the first task would be, what are these types of cells? What are these cells? So for that, what we usually do is we go for immunohistochemistry, which is help for the lineage or what are the type of cells. Can you go to the next slide? Yeah. So this is CD20. What an overview of all three different fragments. What I'm trying to show is, if you see the upper row first picture, that the density or the population of CD20 positive is very high, but whereas the other two are lesser. So this is also reflecting what we said in the HE, like heterogeneity. Can you go down next slide, please? So this picture, the higher magnification of CD20 only, what we're showing is a boxcar. Like you see the typical membranous positivity of CD20, and they're very intense. Almost all cells are showing the same pattern of positive, same pattern of positive. So there is no variability or loss of CD20 expression in these kind of cells, which is very strong. So when you get such a strong CD20 positive large cells, your differential of Hodgkin lymphoma stays very low. You don't expect a Hodgkin lymphoma to have that strong positivity and uniformity. Yes, you might get CD20 positive Hodgkin lymphoma, but that usually will be variable, and they never show a complete or uniform pattern. So that is one. So at this point of time, if you ask anything at our first differential should be some of the positive large B-cell lymphomas. But since this is a mediastinal mass and you have you can have an entities like borderline. So you can go to the different other panel of markers. So here, when you deal with the mediastinal lymphomas, there is a certain panel of markers which you need to do. That is, one is it should encompass to detect both PMBCL, Hodgkin lymphoma, and Graves. So because of that, despite we get CD20, so always CD20 should be interpreted with CD3. Next slide. So CD3, what you are highlighting is all the mixed, the smaller T. The large cells are negative. Next slide. Next slide. Yeah. So this is CD30. You can see all the large cells are positive. So here, a bit of heterogeneity you can note, like some areas are showing strong positivity, some are showing incomplete membrane. There is certain variability in the CD30 positivity. Next slide. Yeah, those CD30 positive cells you can see are the large cells. What you are seeing is the PAX5, which is an inferior transcription factor for T cells. Okay. What we are seeing is they're showing very faint green brown color in the that is actually weak positivity in the cell. We are saying that there is some kind of what you can say the differentiation of B cells is not really optimal or the perfect mature type of terminal. So these are weakly expressed PAX5 positive cells. Can you go to the next page? So, whenever we deal with the mediastinal B-cell lymphoma, you should always do a transcription factor of BOB1 and BOB2. This is BOB1. You can see all the large cells are strongly positive for BOB1. Next slide. Why they were negative for BOB2? Yes, it has been interpreted as not clear, but they were negative, and they were negative for EBV, LMP, and P63. Next slide. I just want to add a comment about P63 here. P63 is normally used in the panel of any kind of mediastinal lymphomas because most of the of all the lymphomas, primary mediastinal B-cell lymphoma is shown more than 90 to 94% of the cases are shown to be positive for P63. And this is of late has come in a diagnostic panel, especially to distinguish between Hodgkin and PMBCL or in gray zone lymphomas. Here it is P63 negative. Next slide. That's GATA3. GATA3 is a T-cell nuclear transcription factor. So it has been shown to express in classic Hodgkin. So you can see all the large cells are positive. What to summarize, you have a mediastinal B-cell lymphoma with features like having certain kind of aberrant B-cell expression pattern, in the sense like weak PAX5 expression, no OCT2 positivity. So with expression of T-cell nuclear transcription factor. So normally in a mature B-cell or a peripheral or a mature B-cell lymphomas, you don't expect GATA3 positive, that is T-cell transcription positivity within. So you have a lymphoma with an architectural variability somewhere at the sheeting and the other way is a polymorphous with a diffuse CD20 positivity, apparent T-cell transcription expression, and kind of what you can say not a perfect complete immunophenotype of B. Here there is a limitation whenever you have mediastinal B-cell lymphomas in your panel, you should keep CD79 alpha also, because many times PMBCL they're positive, okay, and EBER can also be done if LMP is negative EBER, because the sensitivity picking for EBV virus and EBER is marginally higher in Hodgkin lymphoma. If it is EBER positivity, you stay away from either gray zone or PMBCL. With this kind of pictures, I will like to offer the diagnosis as a B-cell lymphoma with features intermediate between classic Hodgkin lymphoma and DLBCL. The only reason we are saying despite being CD20 positivity here the gray zone is because of the aberrant expression of GATA3 and lack of the complete B-cell markers. So That's what anybody has any questions?
So, sir, just to summarize what you have just said, that so in a Hodgkin, when you say you have a strong CD30 positive and CD20 deemed to heterogeneous, not strong as in this case, and an EBB, LMP, or IBR is, that is the FIS of fever is positive, or in the ISC, and if you say a PMBCL where it is the CD30 is weak and CD20 is strongly positive, and PEX5 will be negative. Otherwise, the PEX5 will be dim positive in Hodgkin.
PAX5 will be strongly positive in PMBCL.
Yes.
Okay. And it can be negative or weak positivity in Hodgkin, but characteristically it will be weak positivity. So it's nothing but when 30 is an activation marker. When any cell is an activation marker, the PAX5 expression will be weaker. So it's it's like both are go the similar pattern. Very rarely you will have PAX5 strongly positive and 30 will be weak. Okay. So that is one side. If you look into the differentiation type, what is PMBCL? The PMBCL is the term they use it for the B cell lymphoma with all the intact B cell differentiation program. Whereas in classic Hodgkin lymphoma, which is something disorder or an disrupted B cell differentiation program. And they show that. So that is our main goal, to see whether this is a B cell, completely B cell differentiated neoplasm, or is it any kind of disrupted or disordered B cell differentiation. Here, yes, the expression of GATA3 tells you that there is something more than T cell differentiation. So GATA3, the T cell marker, nuclear transmission, is showing positivity here. Okay. So what are the limitation here? We are not done CD23. So 23 has got a very good positive predictive value for Hodgkin, for PMBCL, and as like P63. Your P63 is negative. So 20 positive, but P63 negative tells that it is unlikely to be, because more than 95% of PMBCL are P63, unlikely to be typical PMBCL. So for what is the problem for classic Hodgkin lymphoma? Yes, there is the amount of CD20 positivity is too strong for an Hodgkin, and it did not show any kind of heterogeneity in CD20. Yes, I agree. We have not done CD15. 15 would have filtered. If 15 positivity would have filtered in favor of Hodgkin. But so, whereas what is the features which is more closer to Hodgkin? The aberrant expression of GATA3, lack of OCT2, the weak expression of PAX5 are more features similar to Hodgkin. So if you put it in there are some features which are favoring for PMBCL, some features which are favoring for Hodgkin. That is why the terminology what we use is B-cell lymphoma, which features intermediate between Hodgkin lymphoma and classic Hodgkin lymphoma and PMBCL.
Thank you, sir. So, I think one thing about the differentiation between classical Hodgkin, PMBCL, and so it seems that we have to rely more on the IST. What are the morphological factors which you think that can help also?
So, see, the conventional, what we said, no less than 10% of the neoplastic cells and all, they are very nice with this convention, but in reality, it is not true. So, there are variants of Hodgkin lymphoma which can have more neoplastic cells, like the syncytial variant of nodular sclerosis. Okay, that will have sheets of large cells on the, or RS-like cells. So, you might looking at HE and architecture will be diffuse architecture. Whereas lymphocyte depleted classic Hodgkin lymphomas, they will have neoplastic node cells. So these kind of subsets or certain sites of diffuse variant of lymphocyte rich classic Hodgkin lymphoma, they will look more like T cell with B cell. So these are nice, the histological pattern, but that does not tell you that it is the sacrosanct for that these features are very typical or classic of Hodgkin. No, it always has to be capped by or kind of supported by the immunoprofile or immunohistochemical findings.
Yes.
So here I have to tell everybody, like, PMBCL and Hodgkin lymphoma probably biologically more closer. So you can have somewhere, like, at one place you will have a typical PMBCL immunophenotype, and other places you can have a Hodgkin. What is you need to understand is PMBCL are never, almost you cannot say anything never, they're usually EBV negative. So whenever you get an EBV positive B cell lymphoma, So you need to think that possibly we are looking at some subset of an Hodgkin with an architectural variation rather than gray or pale.
Yes, sir. So I think the important point for the resident to understand is that the three entities that we are discussing, Hodgkin, Limbicel, and Gray zone, they all have three different biologies with different prognosis as well as the treatment planning. So I think the differentiation between the three entity is of paramount importance whenever you plan a treatment. And as sir nicely alluded the ISCs also. So Madam has asked about role of ML and serial. Uh,
Okay. Can I go ahead? No, should
yes,
I?
sir. Yes, sir.
So, okay. Serial is typically seen in a PMBCL, but diagnostic efficacy to distinguish between this is not very strong. It is very useful if you want to say something as a DLBCL, NOS or PMBCL. Yeah, probably useful, but not for gray zone or Asian basically. It will be this thing. So as of now, the current consensus is that when you have a medicinal B-cell lymphoma, the panel which will help you will be LCA. Yes, difficult to interpret. If you interpret properly, LCA has also got a very good role. LCA, 23, 30, category, P63, 79 alpha, OP2, BOB1, 50 and B30 and 15 are the panel which should be used to diagnose better way.
Madam, you want to ask anything else?
Nothing additional from my side, Lingaraj.
Yes, ma'am.
Maybe Lingaraj and all of the oncologist, budding oncologist and Manju. Can I put a question?
Yes, yes, sir.
From the pathology side, because we are having a discussion here. Hello?
Yes,
Yeah,
sir.
go ahead, Sridhar.
Yeah.
Go ahead.
So my question would be, suppose, from the pathology side, somebody says, let's see, 20 positive Hodgkin lymphoma, or what is the difference in your treatment or approach between 20 positive Hodgkin lymphoma, Gray zone lymphoma, and PMC?
Lingaraj, you want to take it?
Yeah, ma'am. So I think, sir, CD20 positive Hodgkin's lymphoma, there is a study from the German group that there is a randomized study of addition of rituximab to the BACOP or ABPD to benefit. So even if it is a CD20 positive Hodgkin's lymphoma, I will treat like a Hodgkin's lymphoma with ABPD or BACOP. Now coming to primary mediastinal B-cell lymphoma and gray zone lymphoma. Now primary mediastinal B-cell lymphoma, the treatment will be more like an RFO kind of chemotherapy. Because that is based on a very small data. But that is one data where can be avoided, it seems, and we can get away with chemotherapy alone approach. And if it is a gray zone lymphoma,
Sridhar, will you be able to? Sridhar, will you be able to mute while Lingaraj speaking? Yeah, go ahead. Yeah.
Yeah.
I am muted, sir.
Yeah.
Thanks, Akhil.
Yeah. So, I told about Hodgkin. Now coming to primary medicinal B-cell lymphoma, so it's based on a small data from NCI about R-epoch regimen. It's a phase 2 single-arm study where 6 cycle of R-epoch and no radiation. Traditionally, radiation was used with R-CHOP backbone in primary medicinal lymphoma, and it's still a kind of standard of care in European countries. But after the R-epoch data from NCI, somehow the practice has changed in our institute, also in various other institutes, that radiation can be avoided to the mediastinum. Now coming to the gray zone lymphoma, again the similar study from the NCI with R-epoch, and again it's a single arm phase 2 data. And when they compared their outcome with PMBCL, the outcomes are pretty bad. If the difference was almost 20 to 30% if it is a gray zone. So, and that is without radiation. So probably if it is a gray zone lymphoma, I would prefer giving radiation, even if I am using an R-epoch. Now, coming to the chemotherapy backbone, there is no comparison, as I said. So as radiation can be avoided in patients with primary mediastinal, so I will love to know whether it is a primary mediastinal or a gray zone. That is the only difference I can make. And madam, if you want to add also.
So I think his question predominantly was CD20 positive Hodgkin's lymphoma, whether there will be any difference in terms of treatment versus those who are CD20 negative. So as of Sridhar, whatever data is there for rituximab, one, it is not specifically addressing the CD20 positive for neoplastic cells. It's for all, irrespective. In fact, the BACOP trial where they added rituximab was for all. It wasn't specifically limited to the CD20 positive subset. So as of now, there is no evidence that you need to treat them differently. So that's one thing. It's more of a prognostication, but even with the kind of treatment, the role in terms of prognostication is also going down. So no, so answer is whether we say that it's CD20 positive or not positive on neoplastic cells, or whether there are, the background cells, as of now, the treatment doesn't differ.
Okay, I'm just asked because sometimes we find it a lot of difficulty to distinguish between 20 positive Hodgkin and the other subsets. So that's why I wanted to know whether
Yeah,
anything
the distinction between Hodgkin's and PMBCL plus gray zone is important. Between PMBCL and gray zone, it's important from the prognostication point of view. And if it is expressing C gray zone, then the treatment would remain exactly the same as dose-adjusted ARIPOC, except that there will be a need for radiation in mediastinal gray zone lymphomas, versus you can avoid that if the patient has achieved complete response in the mediastinal, primary mediastinal B-cell lymphoma after dose-adjusted ARIPOC.
Yeah, madam, one thing that in a mediastinal gray zone lymphoma, like though there is data that the outcome is poor with ARIPOC, but the data of that radiation helps. I mean, I will involve Sangeeta also here. I think Sangeeta joined. About the role of radiation in gray zone lymphoma if they are PET CR at the end of treatment.
So, sorry, Sangeeta, you want to go ahead?
Oh, no, madam, please go ahead.
Okay. So if you look at traditionally, it means anyone who has bulky mediastinal lymphoma, whether it was primary mediastinal B-cell lymphoma or any other lymphoma, non-Hodgkin's lymphoma, if you're talking about a diffuse large B-cell lymphoma, NOS also, the treatment remains chemotherapy, which is a R plus chemotherapy. And the reason I'll tell you why I'm being vague in terms of chemotherapy, followed by radiation. The entire idea of moving into dose-adjusted ARIPOC and then, not giving radiation is predominantly limited to primary mediastinal B-cell lymphoma. Unfortunately, there is no data for mediastinal gray zone lymphoma to say that you can treat them exactly on the similar lines and avoid radiation. Given that the outcomes are poor, that's the reason why consolidative radiotherapy is preferred in these patients, because many times the disease comes back in the mediastinum, more than just the, rather than extramediastinal, it's the mediastinal recurrence which is common. So that's the reason for using consolidative RT. The numbers are too small and there is no uniform series, so it's more like an opinion-based treatment which happens for mediastinal gray zone lymphoma.
Yes, Sangeeta, you can go ahead.
Yes, so as madam said, and you also said, so there is no definite guideline, but there are few studies, single arm, just observational studies showing that radiation may be omitted in complete responders. But again, because the outcomes are little poorer than PMBCL, so still the consensus in our institute is to give consolidative RT if it was a bulky disease, and but not in PMBCL. So in PMBCL we avoid, but in case of gray zone, just to improve outcomes, we do consolidative RT. But there is no definite there is no definite evidence for use of RT. But still, I mean, there is not enough evidence against or for the use of RT. But to improve outcomes, we still go ahead with RT in case of gray zone lymphoma.
Yeah, thank you, Sangeeta. So as Madam also rightly pointed out that the relapses of primary mediastinal, we have seen extra mediastinal relapses, but in gray zone the relapses are mostly in the mediastinal itself. So it makes sense to give radiation to these areas. So Basu has asked, can gray zone lymphoma has non-thymic origin, and is there any difference in prognosis between thymic versus non-thymic? Sir, you want to take this question? See, sir.
Yeah, of late it has been described to have non-thymic also. But usually they present in advanced stage. I'm not very sure whether the prognostic difference, probably it is because of the stage, because primary mediastinal lymphoma more commonly they're lesser stage, more common. The group can be present in advanced, but non-mediastinal primary mediastinal, mediastinal gray zone, usually they have advanced stage, probably because of that it might carry a worse prognosis. But for all the residents, I just wanted to know, tell you one thing. When you're saying about a gray zone lymphoma, so you just make it one point to this is predominantly in the mediastinal. Okay, there are in the literature they get occurring on the outside also, but we need to, before diagnosing as a gray zone outside mediastinal lymphoma, we need to be very certain, and we need to have an all set of immunohistochemia, and finally you should call.
Thank you. Thank you, sir. Are there any questions from residents? They can unmute and ask. Okay. If not, then I think you can close the class for today. And thank you, Siddha sir and Sangeeta and madam for this discussion. Thank you all.
Thank you very much. It was learning opportunity for me also. Thank you.
Thank you all.